So we have the entire map of Dharavi now mapped out, and each line where it goes, what are the resources available. 5 years we were the ones who were really getting in new vaccines into the routine immunization system, which is given free to the little kids. So AI and machine learning is really contributing a lot.
Hello and welcome to FaceTime with Leaders, presented by Directors Institute, World Council of Directors. I'm your host, Sunny Pancholi, and today we have an extraordinary guest whose career embodies what it truly means to lead with vision and purpose. Joining us is Dr. Satish Kaipilyawar, a trailblazer in public health governance and disease prevention, with over 35 years of experience leading transformative healthcare initiatives across India and Southeast Asia. As the Associate Project Director at Share India, he works closely with CDC, USAID, and the Gates Foundation, tackling some of the toughest public health challenges with innovative solutions. His leadership in high-impact tuberculosis control programs and national healthcare policy reform has shaped the future of global health. Beyond strategy, he has played a key role in securing multi-million-dollar funding for critical interventions, proving that true leadership is about driving real change. Well, we will dive into his incredible journey, what it takes to lead large-scale health programs, how governance plays a role in shaping public health strategies, and what the future holds for healthcare innovation and policy advocacy. Dr. Satish Kaipilyawar, welcome to FaceTime with Leaders.
Namaskar, and thank you so much for having me at the FaceTime, featured at the FaceTime for the leaders. Thank you so much. I really appreciate.
So, Dr. Satish, you have had such a remarkable career spanning decades, multiple countries, and some of the most impactful healthcare initiatives. But every great journey has a starting point. So, can you take us back to the beginning? What inspired you to step into the world of public health, and how has your journey unfolded over the years? Were there any pivotal moments that shaped the path you took?
Sure. Let me actually go back to around 86, 87, where I started my journey. And before that, when there were very few choices in our childhood, only medical or engineering, and then I chose medical to come into the medical. And when I have taken the medical field here, I had an opportunity of actually working for a government in northern Telangana here, and it was a great experience of working with the government for 10 years, undergoing all those national health activities there. So part of my journey was on the clinical side, and a part of the journey was on the public health side. But public health really attracted me more. Clinics was not, it was repetitive and it was all same. So I pushed myself to public health. And I started my journey with leprosy, working for leprosy patients. And during our times, there were very less resources within our ward. We used to really dress people with our hands, and sometimes even we didn't even have gloves for us. So in that difficult circumstances, we have really done this. And one example I would really like to share here was, there was a village leader, a sarpanch, who was suffering from leprosy, and he was a very powerful leader of his time and he was really brought to our ward. He was dumped in the night in front of my ward, and people abandoned him at my ward. So I was working in a ward, leprosy ward, which was an isolated ward across the hospital there. So we dressed him for almost 11 months, and then I did a skin grafting for him. The person who came flat on the bed went walking after 11 months. And he was so grateful to me after he got well, because he again regained his power. He regained his position there in the village and the respect there when we declared him that he was cured of leprosy and his disabilities were. So it was a really happy face which I have seen there. So the beauty of public health is saving lives and improving the quality of the life of the people. And all my 3.5 decades of experience has been really working towards this, be it any organization, be it Gates Foundation, be it USAID, be it PATH, be it the government, everywhere have been working for saving lives and improving the quality of the life of the people. So that really changed, and I got very good opportunities there in working on immunization, working on tuberculosis, working on malaria, working on school health, and the list goes on. So you name a program, I have really worked within the government setup. But the government setup was really not to my liking. So I took a mid-career break, shifted from the government to a development sector. And the development sector, I was really able to contribute more, being outside the system and contribute into the system. So that really was very immense activity and very critical for my career.
Incredible, Dr. Satish. That's truly incredible. And it's always fascinating to hear how these journeys unfold, not always in a straight line, but through moments of passion, challenges, and unexpected turns. So, Dr. Satish, leading TB interventions in Dharavi, one of Asia's most densely populated slums, must have come with an entirely unique set of challenges. So, in an environment where overcrowding, limited access to healthcare, and socio-economic hardships create major roadblocks, implementing effective interventions isn't just about medical expertise, it's about navigating human complexities. So, what I would like to ask you is, Dr. Satish, what were some of the biggest challenges you faced while working in Dharavi? And how did you and your team overcome them to make a real impact?
Yeah. So Dharavi was a great experience, and we had some of the good, passionate team members working for Dharavi there. So it was really very crucial to first understand the climatic situation there. I mean, the environment there, the context there. That was very, very important for us. And many of us have entered Dharavi the first time. We came there with a lot of prior experience of working in rural areas, in urban areas, semi-urban areas. So we brought that wisdom with us, but Dharavi was completely different. I mean, it's such a congregated setting where even the basic amenities, basic water, sanitation and all are really lacking. But a lot of economic activity really happens there. And it is a bhul bhulaiya. In Hindi, if you say it is a bhul bhulaiya, if you can, you have to really navigate through all your routes there. So the first activity which my team did, and selection of team was very important. So we selected very good people who were really motivated, who were really willing to work in that Dharavi slum area. So first activity there we did was transact walk and mapping the entire Dharavi area. So we have the entire map of Dharavi now mapped out, and each line where it goes, what are the resources available. So all that was really done for Dharavi. And while we put our team there, the COVID was actually declared. So COVID shutdown was declared, and many of the staff I have not seen for a year. We interviewed them on phone. We recruited them. They were placed there, but the next day it was a complete lockdown situation. We started for TB work. Like, our role was to improve the TB outcomes there. In the sense, diagnose people, put them on treatment, see that they adhere to the treatment. So that was our challenging role in Dharavi. And entry itself within Dharavi was really very restricted. Access to each household or access to the inorganized sector there was really challenging, because Dharavi is really controlled by some forces there, where unless people really understand that you don't have any motives which are really harmful to them, they will not really allow. So we had to really build that rapport with the communities, with the unorganized sector. And once we developed that rapport, then there was no looking back. They really gave us freedom in really going there. So COVID times, the challenge there was migration. So all the enlisted people who we have listed there, they all migrated to different parts of the country. So, but we had their phone numbers and we preempted that migration earlier only. So we were able to really contact them. We asked them to really connect and go into a health center, so that we talk to the health center people and then provide that thing. One very important thing which Dharavi people have informed us was, आप लोग तो दवा के बारे में बात कर रहे हो, but who will provide us food? Our employment is lost, our shelter is lost, there is no food for us, and you people talk about medicine. So we really had to organize food for them, getting all the philanthropists together, then listing out all the people, prioritizing them, who will receive this rations first, and thus we got the access and then confidence of the people. So all 500 and odd people who migrated out, we were able to touch everyone except for 2 people. Everyone we were able to contact, and we connected them with treatment and drugs. So the failure rate was very high in multi-drug resistant tuberculosis when we started. It was around 29% success rate. We moved from 29 to 85% at the end of our project period. So it was a fascinating work in Dharavi, and it is totally a different healthcare system there.
Absolutely, Dr. Satish, and that's truly eye-opening, actually. It's one thing to understand the challenges in theory, but hearing about the real-world complexities like the human story, the logistical struggles, and the persistence it takes to push through is just incredible, Dr. Satish.
And to add more here, like we have prevented 3 suicides in Dharavi. I mean, they were so frustrated that they were going to commit suicide, but they were very close to our healthcare workers, and they used to phone up the healthcare workers at any time. So one of our healthcare workers really got engaged with the person. We called the 104 ambulance service and sent it to the place there. And then before he was really attempting that, we really prevented those suicides there. So 3 such suicides our team has really prevented on phones. They have not seen each other for all those 8 months. And once this activity was over, one of my healthcare worker got sick and he was admitted in the hospital, and his patient came to know that he was admitted in the hospital, and this person then took a tiffin box to that person for a week. He said, "Sir, aap बीमार हो और हमारे लिए आपने इतना किया है, so we should also be doing that." So that family has supplied the tiffin boxes for almost a week when he was hospitalized. So that shows how closely these people have really worked and connected with each other within Dharavi. People are very good there.
Hats off to you and your team and the dedication it takes to, do such a social work on such a large scale. Amazing, amazing, Dr. Satish. All right. Okay, so let's move ahead. Dr. Satish, your tenure at PATH was filled with groundbreaking work, introducing hepatitis B vaccines, revolutionizing cold chain systems, and securing $7 million in funding for TB programs. So can you take us behind the scenes? What are some of the biggest challenges in implementing these initiatives, and what key factors played a role in successfully driving funding and making these projects a reality?
So PATH experience, I had around 13 years of experience with PATH under various projects there. And it was really fascinating, and I learned a lot of good things because it was an international NGO. So I really got to connect with different other countries also. So it was a multi-country project there. So to begin with, we have started introducing 4 vaccines into the routine immunization system. So these vaccines were getting introduced within India after 35 years of a new introduction of measles vaccine. So 35 years back, measles was introduced. After that, after 35 years, we were the ones who were really getting in new vaccines into the routine immunization system, which is given free to the little kids. So 4 vaccines that were hepatitis B, we worked on HPV, we worked on JE vaccine, we worked on the rotavirus vaccine. These were very important vaccines during the 2000s, early 2000s. So that is the time where we implemented this. So it was a Gates-funded project, and very challenging in the sense the strengthening of the routine immunization system also was very difficult there, because the immunization rates, the success rates were really not so good. So we had to actually first see how the data shows, what the data talks about, how the immunization rates were, and depending upon that, then we developed all our strategies for doing this. So strengthening routine immunization. Then we brought in the technology also. We noted that the injections which were given in India were almost 80% unsafe. So we wanted to really make those injections safe also. So we brought in a technology. We brought in some technical aspects. We improved the processes within the system, and then we implemented injection safety, biomedical waste, and for the entire vaccine program, there is a cold chain also which has to be really maintained. All the vaccines have to be maintained between 2 to 8 degrees centigrade, right from the manufacturers to the point of beneficiary. So the entire chain through which the vaccine flows needs to be really maintained at 2 to 8. So there were a lot of challenges in this also. So we actually built very good quality cold chain systems. New technologies were brought in. As I said, injections were unsafe. Injections were being reused. So we brought in a technology called auto-disable syringe, which will only be used only once and it get locked. And so the disposal of that. So many technologies we really worked on. We worked on jet injectors for the little kids. We worked on the intradermal injections, and we worked on the rabies vaccine also. Rabies vaccine, if you remember the childhood days, it was to be given around the umbilicus 5 ml. And then we brought down the dose when it went into intramuscular, and we further brought in the dose of 0.1 ml, which goes intradermal. So the dose reduction also was really tried in this. This was a very fascinating work, and all this was expanded to the whole of India. We started small in a state of Andhra Pradesh, erstwhile Andhra Pradesh, and from there we expanded it to all across India. Today you will find all this spread across India in all states. The second activity, great activity, there was about the fundraising activity, which only the international NGOs used to get good funding. The local NGOs were really not getting into that funding angle. So we wanted to really build the capacities of the local NGOs and make them capable of building up robust proposals so that they bid for this international agencies. And the messaging during that time was the funding should really go to the local NGOs, so that the local NGOs really work with the international NGOs. The international NGOs bring their expertise, local NGOs bring their implementation expertise. Together, they work and support the government for this. So we have developed consortia of NGOs, build their capacities on advocacy. I myself have trained around 250 leaders, the NGO leaders all across India. And today, many of these NGOs are getting their independent funding from Global Fund, from the World Bank, from the USAID, from the CDC and the Clinton Foundation Union. So that was the situation during the early 2010, 2008.
Dr. Satish, hearing about the level of planning, collaboration, and sheer determination that went into these projects really puts their impact into perspective.
Yeah, so across this, there were also challenges that it was not just a cakewalk straight away. The challenges were, again, the dynamics of the entire NGO system, the who gets a larger pie, who gets a smaller pie. So all those challenges were really maneuvered through, and putting all the consortium together, putting them into a principal recipient, sub-recipient, and sub-sub-recipient was really a challenge. And negotiating all this together was very difficult activity, but we really got that through, and a lot of money started flowing in to the NGOs. Today, you can find some of the finest NGOs really developed during the last 15 years. And though they are independently planning their project, building their blueprints and implementing it all across the fields. So it's a really satisfying work that we have put during the tenure at PATH.
Absolutely fascinating, Dr. Satish. So, Dr. Satish, healthcare has always been about human connection, treating patients, saving lives, and improving communities. So, but for now, with AI and data analytics becoming more deeply embedded in global health, we are seeing a shift, a powerful intersection between technology and human impact. So, in your experience, how is technology truly reshaping global health interventions, not just in theory, but on the ground where it really matters?
Yeah. I would really like to begin this with a research which I had done for TB in terms of chest X-rays. So as I said, I was working in a very remote village where the services of a radiologist were not available. So there was no radiologist in a district. So many of the X-rays which were taken up there were not really read. And so the problem was lack of radiology, lack of the person who reads this X-ray. This was a big problem. So we did a study on the X-rays, and then we took these X-rays to 5 different people, and 5 different people interpreted it in 5 different ways. So the entire treatment really depends upon the diagnosis of the case there. So the treatment also varied. So there was a inter-observer variability of around 45%, 45 to 60% amongst these five physicians who were actually treating them. So that really led to the understanding about machine learning, how to really interpret this, how to really standardize the protocols. So we actually started that way back for the X-rays. Now we have a full-blown program where artificial intelligence is introduced. You just click an X-ray and the X-ray will automatically read and tell you whether it is suspect of TB or not. Similarly, there's another instrument which was developed where you just cough into the instrument and it will likely tell you that this could be TB, and it's a good screening tool which has really come in here. So there are many examples in TB, like the diagnosis of TB itself used to take 8 weeks for a TB to get diagnosed, multi-drug resistant TB, and the patient used to deteriorate within these 8 weeks, and he used to die. So now the technologies have come in, the very disruptive technologies where we can diagnose that. We have cut down that 8 weeks time to just 2 hours. Within 2 hours, we will be able to really diagnose and put him on treatment. So a lot of lives are really getting saved there in the diagnosis. Then we had this telemedicine diagnosing, because all the physicians are not available everywhere every time. So bringing a physician like this Zoom call, talking to a physician and understanding the problems of the patients and really doing. So all the technologies here have really helped in. And in immunization also, I've told you about the auto-disable syringe that was really introduced here. And the vaccine technologies also, which were brought in, also were very, very important. And during my tenure with Piramal Swasthya, we have done a telemedicine program, and also we have done an accident services program where we did a pilot project on the highways. Whenever an accident is met with, the call gets escalated to a call center, and the call center will then directly inform the police, the insurance, the ambulance. So it so happened, and it's very personal to me, that just 2 years back, I met with a serious accident, and my airbags were blown, and it immediately gave an alert to the call center. The call center called the ambulance, the call center called the police, the call center gave a insurance call. So everyone was there within 15 minutes assisting me. And the mic in my car was actually engaging with me, talking to me. And the sentences which I had drafted were all coming to my ears. And really that saved my life there. So ambulance really came in. So the technologies which we are actually we have developed are really helping people to really save lives. So effective vaccine stores management in immunization program also is today completely automated. The moment the vaccine comes out of the company, it is completely tracked with GPS system, where it enters, what quantity is entered, how stocks are distributed, what will be your reorder level, when the order should be, everything is getting automated. And as I said, 2 to 8 degrees centigrade need to be maintained. So any outages of 2 to 8, there will be an incremental alerts which will be given. If the vaccine stores manager doesn't lift the phone, it will go to his boss. If his boss doesn't lift, it will go to the secretary. So we have really developed that system where there is no chance of any failures, like be it a temperature failure, be it an electricity failure, or be it a refrigerator failure. Everything really automatically gets addressed. So AI and machine learning is really contributing a lot in different spheres. So there are a lot of practical examples which we have. Even in Dharavi, we have implemented 2 of them. One is an audiometer. Audiometer is, there's one drug in TB which causes sensory neural deafness. It's a permanent deafness which is caused by this TB drug. So to understand that and to early diagnose that, we have used a simple audiometry. Audiometry is nothing but just a headphone and a tab. So the person will hear some voices and he will just put his fingers on the tab, and we get the recordings. So we will then come to know the early loss of sensory neural deafness. So if that loss is there, then we will really alter that drug for that patient. Otherwise, he will lose his he'll become deaf for the rest of his life. So similarly, the ECG, the point of care ECG, a small instrument which was used at the point of care at the patient's house, one drug, bedaquiline, which needs monitoring of ECG every day for 15 days. And the drug uptake was really not good. Physicians were very apprehensive about putting this drug. So this technology could really build their confidence. Today, the drug uptake has really improved a lot. So I can give many examples which we have really worked on, and it is really I'm very proud that I was a part of the pilots of these different projects. So that really fascinates me. Working in small pilots, making them successful, then expanding it to the wider geography has been my passion.
Tell you, Dr. Satish, that's an eye-opening perspective, actually. It's incredible to think about how technology isn't just changing healthcare, it's actually redefining the way we predict, prevent, and respond to health challenges.
Yeah, also, there are how best we build these technologies also depends upon a lot of data issues. The more you feed in data, the more the statistical analysis the machine learning does and gives us good interpretation of the data. That is very important. Then the flip side of that is, how do we share this data? The de-identified data has to be really shared here, because again, the personal data and other things from the health records, we are not really supposed to. So we will pick up only the de-identified data, and like in the form of X-rays, only the X-rays will be seen. X-rays will be built up behind the scenes, and then they will interpret on that. So we don't have name, we don't have a sex, we don't have anything to identify the individual. So data privacy is really emerging, very important, and that really needs to be respected there. So as I said, more the data, more the machines get intelligent. And also there has to be a balance between the human interface and the machine. So machines can't really fully interpret everything, but there has to be a human touch also to really look into whether it is doing its job in a right way. So we also got a lot of challenges from the physicians also, the radiologists also, when we actually brought in this artificial intelligence on the X-rays. So these people also felt that it is taking away their field, but it was not. This was used only as a screening tool, and the final diagnosis again will be made by the human interface only. So there are challenges also. It's not straightforward that we have gone in there.
Rightly said, Dr. Satish. All right. So moving ahead, as you reflect on everything you have accomplished, what's next for you? Are there specific areas in global health where you still see untapped potential that you would like to explore? That is part A of my question. And beyond that, do you see yourself bringing your expertise into the boardroom, guiding organizations at a strategic level to drive even greater change?
Yeah, that has been actually in my mind, that after having so much of experience, gaining so much of wisdom in this 35 years, how do we really bring this and put them to use for different companies which are really working for this mission of saving lives and really bringing improving the quality of the people. Of late, what I see is within the health system, there is a lot of need for a training, for building capacities, for actually strengthening the human resources. Though there are standards available, the NABH standards are there, the ISO standards are there, the accreditations are happening there. But within the intermediary period, like today, the accreditation happens, but it is again not followed. The same quality of services is really not getting followed till the second accreditation is really done. So in this intermediary period, there is a lot of need that this HR has to be really maintained. Human resources have to be maintained. They have to be retained. There's a lot of turnover within the health systems also. The moment you train people get transferred. So the skill which you have built is really going to different locations. So that is one of the needs which I really felt. And as I gave my personal example, that I was admitted into an ICU, and when I was actually lying on the bed, I saw a lot of substandard services around me. And that really made me think, did we do something wrong? Why am I getting this care today? In this past 35 years, what did we should do things differently so that the quality which we desire, we should get that quality. And if we have not invested properly on this training and building the capacities of the people, then we are really, every one of us is going to face the same thing. So I ended up training all the nurses there, all the doctors there about some good practices around the bedside. So the point I'm trying to make is training is very crucial, and the passion, the motivation has to be really developed within this serving community. And whenever we do a pilot, whenever we do a small experiment and then upscale it, the pilot should be really fast. We should be really doing that fast, and maybe do a quick and dirty assessment and then start implementing and learn while you do. So that is the best way, because we can't afford to really wait for something to really mature and then give the benefits of that to the community later. So I strongly believe that the pilots have to be very short and do mistakes, learn, iterate back, improve on, and move on. So I have an experience here also from a Gates Foundation project, where the immunization project, which we and this was a very challenging situation for me when I was actually attempting this interview. In the interview itself, I had read the blueprint of the entire project, and somehow I was not comfortable with the blueprint. And the entire question and answers in my interview, I have completely turned it to challenging that blueprint and saying that you're taking too much of a long time of 5 years to implement this project in a state. Instead of that, I have a plan of doing it in 2 years, consolidating it in 1 year, and then upscaling it to the entire country in the next 2 years. So by the end of 5 years, you should be really aiming to move to the entire country, not just one state. So that there were a few board members also there in that interview, and that really impressed them. And they gave me time. They asked me to again rebuild it and again show it to them and present them. And convincingly, I could do that, and we implemented that. Today we are seeing that success. So it was a path-breaking and very satisfying experience for me. So, but it was very threatening for me also, because I have gone for that interview. I'm challenging someone on their blueprint at the risk of losing not getting that job. But I really turned that into an opportunity, and it really helped the entire wider audience to get those products all across India. So that was a great learning and experience.
Amazing, Dr. Satish. It's inspiring to hear how even after such an impactful career, your vision for the future continues to evolve.
Yeah, all my 35 years, I have been working. Any organization I'm working for, the mission, my personal mission is same: saving lives and improving the quality of the life of the people, and seeing happy faces in the community. So that is an immense satisfaction one gets when you really have done something for someone in the community. Happy faces, improving the quality of the life, and saving lives. That is the mission. And my mission aligns with the different organizations in which I am working for.
Absolutely, Dr. Satish. All right, so moving ahead, let's dive into the topic of ESG and its impact on your professional landscape. Since ESG principles, governance, sustainability, and social responsibility can be powerful drivers of change, but integrating them into public health isn't always easy. So from your experience, how can we make ESG a core part of healthcare initiatives rather than just a framework on paper?
Yeah. So, I mean, a lot of investment goes into building these concepts of governance, sustainability, and social responsibility. So these three important aspects, I have an example for each of them in my projects which we have really worked on. So I would take an example of governance. If you take the governance, the northern states and the southern states, we see a lot of good governance in the southern states, and so any developments and all happen more on the southern and the western part of India first. So we had one opportunity of working with the Gates Foundation for introducing hepatitis B vaccine. Hepatitis B actually is a preventable cancer, a cervical cancer, preventable for women. And if before a girl attains her menarche, if we actually give this vaccine, this cervical cancer is prevented. So that is the problem for, and this vaccine was actually available within the market. So we wanted to actually see how this vaccine, if we put it into a general health system, how will this be taken up by the system? What will be the access? How people will access this? Will there be any opposition for this, or will the system really accept it? So by doing this, we learned a lot of things on the governance, sustainability, and the social impact of all this. So I'll narrate this as an example so that our audience will be in a better position to really understand how difficult or how easy it is to really navigate through, rather than just talking about theoretically about the framework and all. No, I don't want to do that. So before we actually implemented this, we actually wanted to understand the context of the field. So how is the field, whether the field is responsive, whether it is going to accept the vaccine, the idea of vaccinating a girl even before something is going to be there, or do people know about cancers? Are they really aware about that? So a small formative study was done with all the stakeholders, the girl child, the parents, the significant people who are making decisions in the family, the school teachers, the hostel wardens, and the religious leaders there. So all these people, we met all these people. We had good focus group discussions and got their perspectives. Once we got this perspective from there, then we designed a strategy to implement this. So designing a strategy again included what were the gaps in awareness levels. So we built up those awareness levels. There was a gap within the demand generation. So we really built up that demand within the field. And so we wanted to actually try this all across in 3 regions, tribal, urban, and rural. So that we get a mix of all this. And when this vaccine gets into the system, it will really affect. So we selected 2 states. One was in western part of India and one was in southern part of India. I don't want to name the districts because of the political affiliations of these states. So the governance levels at these 2 states were completely different. The responsibility taking by the government, the social responsibility taking by the government were better in the western part of India rather than the middle part of the country. So we saw a lot of differences in these 2. So when we actually started implementing this, we had a big plan. We had a good HR, logistics, supply. Everything was properly planned. And we placed all this into 2 of the states here. So the implementation was very well monitored. There was a participation from the local governments at the western state. And there was not that good participation at the southern state, one of the southern states. So we saw a lot of difference between the governance there. And so the implementation of the program also got really affected in a way. There was the best planning, the same planning which we had for the western state, the same planning we had for this. So as I said, there was a differential in the governance. And so we were able to perform it better in the western part of India and rather than in the southern part of India. There is a big challenge. Suddenly, some groups have started within southern part of the country where they said that HPV was really not required. Why is it really given to the people? So they blocked the vaccination program and they closed the program in southern part. But whereas in the western part, the government was very proactive. They took it up. They put financing within that, and then they started the vaccination program for the girls. And the adolescent health program started in the western part of the country. So the point I'm trying to make is a lot depends upon the governance, a lot depends upon the political system, a lot depends upon the willingness of and the local leadership in taking, in spite of your robust planning, in spite of your robust formative study, and in spite of your implementation strategy. So this too is a very good example. And the failures in the southern part also have given us very good lessons as to what were the concerns of the people there. How do we really address those concerns? How do we really rebound back within that? And it took almost 10 years for the country to have this setback because of this particular reaction within the southern part of India. Now the HPV is given all across, but there was a loss of around 10 years for our adolescent girls within the southern part of India because this was not really implemented. So, so the context, the governance, all really matters here. And now coming to the sustainability part, we had a very good model at the Gates Foundation where I will talk about the funding model. The funding model which they brought in here was first year total 100% funding would be given by the Gates Foundation, and the second year 20% would be put by the government and 80% from the foundation, then 40, 60, and slowly we withdraw. So that was again a funding model which really worked. And today government is able to put 100% of the money. It has become a line item within their budgets. So this is a good incremental funding model which we implemented and which was successful, which is really seen by different states. Even Gujarat also has implemented this model, taking technical assistance 100%, and then and TB infection prevention and control also. Right now, we are using this model of sustainability. In the sense, the first year, the first time, we supported the health institutions to do their assessments. And in the second assessments, we together did. In the third assessment, we were out and they were doing. In the fourth assessment, they are completely doing it now. And in the sixth assessment, we are only virtually giving them support on Zooms. So people are able to really take this. So transfer of technical assistance from participation to a non-participation to virtual, and now it is sustained. So the sustainability models, these two models I can really very proudly talk about. And then the social responsibility. So how do we really bring in social responsibility within the health projects? So we had a project on school health, working with the school children, actually working with the education department and the school department to really do these health checkups for the children, give them first aid if something happens within the school, and also integrating health topics, integrating moral science within the teaching curriculums, right? Talking about science within maths, talking about science within social studies. So how do we really integrate different teaching health messages within the teaching methodology? That was really designed and really put forward. So child is a very powerful communicating tool. The moment the child comes home, the parents will ask, what did your teacher tell you today? What did you learn today? So he will say, I have learned about this. I have learned that there are a lot of people who are coughing, who could be tuberculosis, or there are a lot of people who are smoking. So health messages directly reach the homes. Parents really value that. And child-to-child activities and child-to-parent activity and the parent-to-community. In the rural villages, even the community people sit and talk. Today, my child was talking about this. He probably tells to other communities. So there's a lot of scope of really building up this health messages from the school into the community. One last point I would like to really mention here on this school, that children often, they don't like palak, they don't like vegetables, and every parent really struggles to give this to their children. And in one of these projects, what we did was in rural areas, there is a lot of land available around the school, 5 acres of land. And so we chose that school and we said that, okay, this particular land belongs to the 5th class, 5th standard. This particular belongs to the 7th standard. So we demarcated areas and we told them to really put this palak there, the brinjals there, the tomatoes there, and different vegetables there. And so the children started growing those. They have seen the fruits there. And then the teacher said, who is going to take this produce? If you are going to take this produce, please go home, get cooked, and tomorrow we will all have a feast in the school. So the child picks up the palak, goes to his mother, tells her to prepare a curry of that. The curry comes to the school. It's a lunch which is enjoyed by people. So creating an interest for the children to really eat healthy food, eat what is required. And the same message also goes to the mother, the pregnant mothers, the needy people within their household. So this exercise also really got very successful. One of the tribal areas, we found a lot of eye problems, the vision problems because of vitamin A deficiency. And so I was traveling back from my tour and I got a lift. My vehicle got punctured and I got a lift into the social forest officer who was going towards the town. So he picked me up. And while we were going, we were just talking about, so I was exchanging my health experiences. He was talking about this social forestry. So then we said there's a lot of vitamin A deficiency in this place, in this particular village, and we really want to do some intervention here. So he said, Dr. Sahab, if you can actually get this papaya plantation, you get a yield in 9 months. So if papaya plantations are done in that village, we can actually do this. So we introduced a negative incentive scheme. We said that we are not charging for this papaya saplings. The papaya saplings costed 2 rupees for there, and 2 rupees also during that time in the 90s was a great thing for the tribals to really take that. So we said we are going to give you this free, put it in your backyard, grow this. But the thing is, if the tree dies, you'll have to pay us 2 rupees. So they took care of the tree and they got the produce, and the children consumed this papaya. So the vitamin A deficiency really came down. So this is how we have integrated the social forestry and the health problem within a tribal area. Today, the tribal area is actually producing a lot of lorry trucks full of papayas, which are getting exported to different parts of the state. This is in Adilabad district. Thank you.
Amazing, amazing, Dr. Satish. And that's such a crucial perspective. You know, it's one thing to talk about ESG and, as an ideal, but hearing how it can actually be embedded into public health in a way that drives real impact is incredibly powerful. All right.
Without knowing these principles, we actually implemented this. When I actually retrospectively look back at this principle, when I read these frameworks and all, so everything is really fitting in there. We have already done this. I mean, so there are refinements which are actually required for getting these things into back into the field and getting these things into these experiences into the boardrooms and really convincing the board to really take up some new innovative projects for the companies. Yeah, thank you.
Absolutely. Absolutely, Dr. Satish. So that brings us to the last question of the session, and here it is. Dr. Satish, stepping into the governance space with Directors Institute must be an exciting shift. So how has this experience shaped your perspective on leadership and decision-making at a board level?
As I said earlier, there is a lot of vast experience which is available and which needs to be really put to use. So what next? What next was a question. I mean, for me also, equipping myself with the industry trends, to look into the AIs, to look into the different frameworks that really work. And the Directors Institute is really providing this opportunity to really giving this mentorship for me to understand the new concepts, understand the boardroom as to what the boardroom can actually do in enhancing the public health. So not many big companies are actually working on the public health, like we see in the corporate, like we see in the other industries. This is a unique area which I thought would be really explored, and the corporate social responsibility of different companies, if they can really build some foundations and really take up this health activities as their corporate social responsibility, that would be really great. And I think that need is emerging right now. So we need to really strike at the decision makers level. So board is the right place where the decisions are made, and we need to really understand the entire board structure. What are the perspectives of different board members? How do we influence the decision making there? That is very important there. So I can again give this by an example. This example I have tried in 1995-96, where the first polio round was actually made within that district, and we made elaborate arrangements from the district collector's office. And once the polio arrangements were done, the program was implemented, everything was over. At that time, then there were a lot of disabled people who were afflicted by polio, and the government was actually not addressing that issue. So I went to the district collector and said that, sir, we have done something for prevention, but there are already people who are disabled who really need support from the government, and we really need to take care of them. And that particular district, there was not even a single orthopedic surgeon available who would certify that this individual is disabled. So that was the situation in that backward state, in the backward district. So he said, then do you have a plan? Can we do something? Come up with a plan, and then we will do this. Because I said it will really require resources, funding, and all. How do we really manage all that? Leave that to you. Don't talk to your health department. It is going to be collector's program, and then we will do it. So he gave me a time. He said, in the next 15 days, I'm calling all my revenue divisional officers, and you come and share your ideas within this meeting. So I already had got one decision made, 1% change on this, that something needs to be done for these disabled people. So then in that RDO's meeting, collector gave me a half an hour time to discuss with the RDOs, to discuss my plan. So in that, I then gave them a wide picture saying that more than 10,000 people within this district are really afflicted with either one of the disabilities, either a polio afflicted, or hearing impaired, or blind, or different disabilities, and they really need to be provided some social support. This I'm talking in 1995. So there was no government program designed during that time, and that really attracted all the young RDOs. They were all young IAS officers who were actually their first postings within those revenue divisions. And I folded a plan. So we said that we are going to get all these patients from different localities to 2 different spots within the district, and then do a screening program there. So screening program to see that who is really required, whether that person requires a surgical correction, the person requires only a certificate, or he will require some social rehabilitation. So these 3 categories were actually screened within these 2 centers, and we did almost 5,000 certificates were issued. So even there was no designed certificate which was actually prescribed. So I had to design a certificate, and we'll have to put two pictures, one lateral view and one front and back view, to actually show the disability. And then the orthopedic surgeon has to sign, and then there is a civil surgeon over and involving who has to sign. And district never had a civil surgeon and a orthopedic surgeon. So we actually invited people from Hyderabad to that particular district. They the collector made them stay for 3 days there, and then we issued 5,000 certificates. We did around 300 corrective surgeries, polio corrective surgeries. Calipers were given. Jaipur foods were actually ordered there, and we did all this. No funding was available. All the RDOs, they generated funds within their divisions, and then everything was put in place there. So it was such a tremendous experience. And for the concluding session, there were 4 ministers who came and took the show in that districts, and all these things were distributed at that time. So it really required a lot of planning, and one single thought could really change so much without having a penny in the pocket, is really what really needed to be done. And I think boards have the capacity to do that. And to do that, we will require good advocacy skills. Like, there might be concerns for some board members. They might have some concerns to implement something. So understanding each one's concerns, addressing those concerns, satisfying them, converting them to what you want, and then really getting that decisions out. These are very crucial steps within the board meetings, which I feel. And I remember one of the secretaries had said that before a meeting is concluded, your minutes of the meeting draft should be in your hand. All the decisions which you want to be done should be there in your draft. So I always follow that. So if I go into a meeting, what I really want from that meeting out is already written and drafted in my hand. So I navigate through that, and there is a lot of preparation which is required. Who is opposing you? Who is favoring you? We'll have to really work behind the scenes, change people, and get consensus, get them to the board, and then the decisions are made, and then the positive things are really. So it requires a lot of groundwork. And I feel I'm really now ready to take up this kind of roles, so that I can really bring in my expertise to the boardrooms.
Absolutely, Dr. Satish, absolutely. And it's fascinating to hear how stepping into governance has added a new dimension to your leadership journey. So conversations like this remind us that leadership isn't about staying in your comfort zone. It's about stepping up, making tough decisions, and driving real impact where it matters most. Dr. Satish's journey is proof that the right mindset, strong governance, and bold action can transform not just industries, but lives. So thank you so much, Dr. Satish, for joining in.
Thank you so much for having me, and for this session. Thank you so much.
And as we wrap up, here's something to think about. What kind of a leader do you want to be? One who follows the playbook, or one who rewrites it? Remember, the best leaders don't just adapt to change, they create it.
Yes.
So that's it for today on FaceTime with Leaders, presented by Directors Institute. If you enjoyed this episode, share it, start a conversation, and most importantly, take these insights and turn them into action. I'm Sunny Pancholi, and I will see you next time for another deep dive into the minds shaping the future. Until then, keep leading with vision and purpose. Thank you so much and have a nice time.